Welcome to episode 7, surgical options for burns. And today we are joined with Anne and Liz as usual. And we have a special guest today is Dr. Bird. So today is a BurnCast instead of a BurnCast. And we're going to discuss what you should know about surgical options for burns. Dr. Bird, could you start us out by introducing yourself and telling us a little bit about what your day-to-day life is like here at Children's?
Yeah, so my role is I'm the chief of trauma and burn surgery, and in that role, I do, as far as burns, I do burn care. I see patients as outpatients with our team. I help do the operations for the burn patients. I've been doing burn care ever since I was a resident and been director at 2 different hospitals of pediatric burn care over the years, and it's been of clinical and research interest of mine for quite a while.
And what was it about burns that was so intriguing to you?
Well, it's a challenging it's a challenging field. The kids with burn injuries, whether they're small or large, require strategies and planning for surgical care. And then I've done this now for a few decades, and the kind of things that we do now are different than what we did 30 years ago. And so this is a field that's ever in evolution. And for those of you who've been able to go to the national burn meetings, the number of products and options that we have now is more than ever. And the options that we have now for taking care of kids are better than ever. Not just kids, but adults for burn patients in general are better than ever. So I think this is a field that is very much in play and very much active.
So when we're talking about burns that are going to need a surgeon and a surgeon like you, what is it about a burn that makes you get involved? Like, do you see every single burn that comes in, or does like Anne consult you, or like how do you know that it needs surgery, and how do they get to you?
Yeah, so I don't see every burn patient. I am aware of almost all the burn patients, and especially burn patients who have long-term needs for outpatient care, whether they have surgery or not. But I most become involved in patients who have deeper burns, or where we begin a discussion about whether or not an operation needs to be done, whether that patient comes to the emergency department, comes through the clinic for the first time, or is transferred to our care at the inpatient setting. And my role as a surgeon is to look at that burn together with our team, and we have a fantastic team of really experienced MPs. Together with our team, look at a burn and make a judgment about what the best course of care is. Sometimes that best course of care is to let the wound heal with some kind of dressing strategy. Other times that best course of care is to immediately proceed with surgery if the injury is deep. And sometimes that best plan of care is to just see what happens and make a decision about what to do later.
So what does it mean when a burn needs surgery? What happens? Like, what do you do with a burn that in the operating room? Is it always the same, or do you do different things?
Yeah, so generally the burns that require surgery are burns that are deep enough that they will heal, but will take an extended time to heal, or will heal with a lousy scar. And so there's a general rule of thumb that we use is if you predict that a burn will heal within 3 weeks, and there's some caveats to that, but generally within 3 weeks, then it's probably reasonable to proceed with letting that burn heal. Now, the caveat is if the 3 weeks is some kind of miserable experience for the kid, then you may want to not wait that 3 weeks and to do something to take care of it. But generally a burn that takes longer than 3 weeks to heal will have several implications for the kid. The first implication is it's going to require lots of dressing changes that are potentially painful, time-consuming, and disruptive to the life of the child and the parents. The second thing is that if the burn is deep enough and it's not able to heal from the underlying dermis, it has to heal from the sides in. And when a burn wound heals from the sides in, and the burn is large, that takes a long time to heal. And when that process happens, when the burn heals from the side in, the scar tends to be thicker, more reactive, more sensitive than you could achieve if you did an earlier operation.
And can you explain more about like how a burn heals? Because when you were saying that when it's deep enough from healing from the sides in, so for the regular wound healing, can you explain a little bit about that and how that works?
Yeah, so when you have a burn injury basically the way to think about it, you have what we call superficial partial thickness injuries, which I think in first aid classes they call first degree burns. That's the typical burns that you get where you're working on the stove and you maybe get a small splash of hot water in your hand, you have a blister, and within a day or so that's healed. The next level of burn is the burn that goes through the epidermis into the dermal layer. And depending on how deep the burn is into the dermal layer determines how well that burn is going to heal. If it heals far enough into the dermal layer, the dermal elements that lead to the skin to heal from the bottom up are injured. And so the only way for it to heal is the surviving dermal elements and surrounding burn tissue. And so our job, and this is what we do all the time, is we look at a burn and we have to make some projection about what that depth is and what the likelihood of that injury is healing from the bottom up or from the sides in, and making a decision about making a reasonable guess about how long that process will take.
So Anne, as being one of our fantastic and amazing nurse practitioners, if you're more likely to see these kiddos that are going to need surgery, you're the one that's going to like bring them to Dr. Bird and talk about them. When you do that, do you guys do that together? Does Dr. Bird come down to clinic, and then to follow up with that, do you go to the OR with Dr. Bird when he does surgery for that?
Yeah, that's a good question. So it depends on how the patient presents. Some patients, when they present with a full thickness injury that we know probably needs a graft, it might be in the emergency department, or it might be that we see them in clinic. Either way, Dr. Bird or one of our other burn surgeons, if they are the one who's kind of the burn surgeon of the week of that week, I'll reach out to them, or one of our other nurse practitioners will reach out to them. Sometimes they come to clinic. Sometimes I know Liz occasionally at our other clinic site, she'll Zoom in our physician so she can get one of our surgeons virtually, and they'll either see it in person or they'll see photos. We have a way of uploading photos into patients' medical records so that the team can see pictures of burns, which, a picture is worth 1,000 words, especially when it comes to burns, because it can be really challenging to describe a burn. It's not usually, it's a very heterogeneous picture. It can be areas of partial thickness, areas of full thickness. So that's how we, depending on, what the burn looks like, if we think it's not going to heal within 3 weeks, or it's one of those depths that Dr. Bird was talking about, then we'll get them involved. The second question about going to the operating room, I go oftentimes to assist with burn dressing changes. Not as much with the true scrubbing surgical procedures themselves. That's more of a surgical skill, which I don't have as much of the training for that. But I am often in the operating room when it comes to our burn patients. Dr. Bird, oh, sorry, go ahead.
Oh, no, go ahead.
I was going to ask Dr. Bird, most of what it sounds like you're discussing is our patients who come in that have relatively outpatient managed burns in terms of surgical management, like we decide whether or not they need it. What about the large burns, when it's a large TBSA, and what is the surgical kind of process look for somebody who has 20, 30, 40% burns?
Of a flame, like a flame burn, because we know that's going to be deep.
Yeah. So I mean, the vast majority of burns that we see in pediatrics are small burns. The majority are less than 5%. I think probably most are 1 or 2%. I mean, that's almost what they are. But we do have kids that are in the hospital with larger percent burns, and we generally in pediatric burn care, generally burns that are greater than 50% are pretty unusual. So if we have a kid who's admitted with, say, a flame burn that's, say 20 or 40%, then there's all the strategies sort of change. So our initial focus is on initially resuscitating that kid. There's tremendous fluid loss associated with burn injury that requires sort of a multi-phase resuscitation plan that's done in the ICU with the collaboration of our ICU team. Very quickly, we need a plan for how to manage the burn wound, especially if it's pretty clear that the patient has a deep injury that's either injured all the way down to the fat, or likely is injured deep into the dermis, which regenerates new skin. So then we have to come up with a sort of a staged plan about going to the operating room. So if it's a large burn, it's really not feasible to do skin grafting on a large area. It's not only a long time in the operating room, it's not only a large amount of blood loss all in one time, but it also has it also you may not have a clear idea early on about what's going to heal and what's not going to heal. So early on, what we do is, as a team, come up with a strategy for surgical management, and we prioritize areas of function. So if a patient, for example, has a full thickness hand burn and a full thickness thigh burn, then we obviously want to prioritize that full thickness hand burn to get the patient back into, get that area healed, get the patient back to normal function. So there's sort of prioritization. And then there's, sort of timing of things. So we have to, work with our operating room schedule, which, we don't have unlimited access to the operating room. So we have to be strategic in how we plan the different stages of the operative care. And so in a lot of this, our initial plan, we'll come up with an initial plan of like what our priorities are, what we think is going to happen. But burns surprise us all the time. You may go and see a kid one day and say, here's our strategy. We're going to do this area of the body first, this second, and then come in the next day and be surprised about maybe a injured area of skin looks a whole lot better, or vice versa, that an injured area of skin suddenly looks bad. The burn is converted to something that is obviously deeper. So this is, we're making decisions dynamically for these patients. Start with an initial plan, but be prepared to change that plan as time goes on.
So I think you brought up some really good points about when a child with a burn needs to go to the operating room. So, and this is a little bit, I think, a little mystical for bedside nursing and a lot of staff. So if a patient goes to the OR, they aren't necessarily having surgery. Sometimes they're just going to the OR for a dressing change, correct?
Yeah, so so it may be confusing because it's all in the operating room, and the operating room is a place where surgery is done.
Right.
But there's different things that we do in the operating room. So one level of thing we do in the operating room is simply do a standard dressing change. We put a topical on or a silver impregnated dressing, and just literally just change the dressing with the patient asleep. And that's something we do in, for example, a child who has had a bad experience with previous dressing changes, is highly anxious. It gives us a venue for doing the proper dressing change and looking at the burn wound in a way that you wouldn't be able to do if you did this at the bedside or in the clinic. The second level of things that we do is that we have patients who have burns that we have some reasonable expectation that will heal, and put on more elaborate dressing. And one of the products we put on is Suprathel, which is a synthetic skin coverage. And that requires gently abrading the surface of the burn wound and putting the material on. And so that's sort of the next level of things that we would do in the operating room. We do in the operating room because that gentle abrasion of the burn wound is not something that you'd want to do with a child awake. Plus, we need to do it with sterile conditions so that we decrease the chance that it gets infected. I mean, the next level of care in the operating room is to do skin grafting. That's basically where you remove normal skin from one area of the body and put it on the burn wound that's been cleaned up of devitalized skin, or to use cadaver skin as a skin substitute. And I guess the final general category of things that we do and actually do a fair amount is dressing takedowns. So we maybe did a skin graft or put on a temporary skin coverage material, and we want to really get a good look at it. Or we want to get a look at it and maybe have a big fork in the road that if looks like it's deep and needs skin grafting, we proceed. So I guess the fourth category of visits to the operating room is to do dressing changes after a procedure has been performed. So there's all kinds of reasons we go to the operating room. Only one of which, and probably the less common of which, is to actually do a skin graft.
So when you do a skin graft, you said that you take skin from one part of the body and put it on another part of the body. Do you do that in the same day? So do you like take off the skin and then reapply it at the same time?
Yeah, so you do it at the same operation. And so, there's different strategies to do it, but the general strategy is you take, you start with the burn wound and get rid of all the devitalized tissue. So you basically, have a special knife that looks more or less like a very sharp cheese slicer, and you use a controlled technique to get down to normal healthy tissue, and generally that's normal bleeding healthy tissue. And then at that point you either can just leave it like that. But then the wound will just have to heal, and that's not what the purpose of that, or you need to provide some kind of coverage. And there's really different kinds of coverage you can provide. You can use cadaver skin, and the body basically gets tricked into thinking it's own skin and will start the healing process as if it's its own skin. But eventually that skin will not be incorporated, will basically not be incorporated. Or you can use the patient's own skin. And when you use the patient's own skin, you find an area in the body that is good for a donor site. We have what's called a dermatome. A dermatome is a air-powered device. We're getting a battery-powered version of it, but basically it has an oscillating blade that's able to take a super thin layer of skin. And you can take that skin, that 8,000th of an inch to 12,000 inch or 15,000 of an inch, whatever you want. Because you're taking skin really thinly, the area where you're taking it from has a high potential to heal. And in fact, most of those areas heal and heal quite well.
Can I show a quick Google Images photo of a skin graft that I just found? Is that okay?
It's a Google image. Yes.
I Googled.
Yes. And while you're showing it, Dr. Bird, I've seen a lot of skin grafts. Why does it kind of looks like, I don't know, it kind of looks like a mesh almost. So yeah. Why is it a mesh? Like, why are there so many holes? Why don't you just take off the layer without holes? Because I feel like they could, our kids can see the holes forever. Like, why is it done that way?
Yeah, so so the kind of think about skin grafts, there's full thickness skin graft where you basically take the skin all the way down to the fat. So you're taking all the dermis, everything all the way down to the fat. The advantage of a full thickness skin graft is that it will heal with less contracture, less shrinkage. It will have a smooth, more uniform appearance. And because it has all the dermis, it will have a more normal appearance and configuration when healed. A split thickness skin graft is one where you deliberately use the dermatome device to take a super thin layer of skin. So you leave the dermis in place, but take everything above you take a little bit of dermis and you take the epithelium, and the underlying dermis that you keep has the skin elements that allow it to re-heal, so the donor site will heal. And so this sheet of skin in this picture, there's a picture there taking a sheet of skin. And you can either take that sheet of skin and put it on a recipient site, a site that's been debrided of non-viable tissue, got down to good bleeding tissue. You can take that sheet graft and just put it right on there. And that's a great option for certain locations. It's a great option for areas of cosmesis. So your face, leaving the sheet graft is good. Your neck, your hands are part of your body. You show the world. So cosmetic areas, or sometimes even for when you have a very small burn injury, leaving a sheet graft is a good idea. But the problem with the sheet graft is that if there's any fluid that accumulates underneath it, it doesn't have any place to go. So even though we do some maneuvers to try to let the fluid out from underneath the sheet graft by basically putting some slices or pie crust and there's some nicks in there to allow the fluid to drain out, sometimes the skin gets elevated by the fluid that accumulates underneath it, and then the skin doesn't heal either all the way or in parts. The other problem that you get into is that it's essentially a 1-to-1 ratio. So when you take a piece of skin let's make something up 2 by 2 inches, and you move it to as a sheet graft with no meshing onto an area, you basically cover up an equivalent sized area. So if you have a patient who has 20% burns, then you would be taking donor sites from 20% of their skin. And that's a tremendous metabolic burden. It's a tremendous wound healing management issue. It's an incredible amount of discomfort. And so that's why we use, to get to your question finally, is that's why you use meshing. And the meshing process, what it does is that we have a device, and there's different devices that do that. We have a device that basically cuts small slits into the skin. It's sort of like at my family at Thanksgiving time, we're making pie crusts. You take that sheet of dough and you put several slits in it, and then you kind of spread it out. And that's what it does, is that the meshing allows that skin to be expanded. And we have the provisions to expand it based on how you do the slits. So the mesher, we have mesher devices. You can have the mesher produce something that's a ratio of 2-to-1 or 3-to-1 or 4-to-1. So you can expand it to those ratios. So you take a piece of skin and you can literally double the surface area that you can cover. And again, you reduce the donor site, you reduce the dressing change, you reduce the discomfort, all those things that are associated with donor sites. And it solves some of the other problems. Not only it allows you to take a little bit of skin and use it in a larger area, but because it has these interstices, it allows fluid to escape. And so you don't have this pockets of fluid that may form underneath a sheet of skin. And so the healing is generally better. Now there's a trade-off for this, is that every little hole that is open in the interstices of this mesh skin graft now has to heal from the sides in, because again, you're putting it on a site that doesn't have the ability to heal from the bottom up. So it sort of needs to heal from the sides in. And so so when you mesh the skin graft, you tend to have more scar than you do with a sheet graft, because you have to fill in those holes. And then the point that you brought up, Cindy, is that that mesh pattern is generally permanent. Now it fades away over time as the skin matures, but it's a lifetime of that mesh pattern will be there. There's things we can do to improve that, laser, just plain old time. But if you see somebody, 20 years later, 30 years later, who's had a mesh skin graft, as a burn surgeon, if I see somebody with a mesh skin graft, I know they've had it. that pattern doesn't really go away.
That's really interesting to know like why that's done. And it makes a lot of sense that if a kiddo has to have like a 20%, like they have 20% that needs to get covered. Now, technically, if you did the same amount, you'd have 40% of the body that didn't have intact skin.
Yeah, so you're absolutely right. So if you do 1-to-1 ratio, you have a patient with a 20% burns that needs to be grafted. Now you have basically 40% of their body that needs to heal. And so if instead you take an area and mesh it to 3-to-1, then your donor site burden is substantially reduced. But there's a trade-off. There's a trade-off in the permanent appearance of the scar. There's a trade-off as far as scar formation, more likely to scar because you have to fill in those interstices rather than having them healed right away.
And so how do you, two questions, what type of dressing do you put on the area that you took the skin from? And the second question is, so you like took the skin, you put it through a mesher, now you have 3 times as much as you started with. How do you get that new skin to stick to the part that you want it to heal? Like, how does it stay in place?
Yeah, so to answer your first question about what you put on the donor site. So, generally donor sites heal well if you're taking them in a controlled manner. And they heal generally between 7 to 10 days is pretty typical. It may take up to 2 to 3 weeks to heal, but they generally heal. And by heal, I mean the epithelium grows over the area. And the general concept that I think the literature supports and big reviews support is that you want to create a moist environment, not do a dry dressing, but do a moist environment to allow the donor site to heal. And that moist environment can be achieved with a lot of different dressing options. Our latest version, and in my career, I've seen, I don't know how many different ways to deal with donor sites. So there's lots of different ways to deal with it, but our current method is to use Mepilex AG. And Mepilex AG has the advantage, it has a little bit of silver in it. And so we're a little skeptical about how much the silver really matters in that particular dressing, but it has silver in it. So it does have some theoretical antimicrobial properties, but it also is absorptive. And so the donor sites will often have a fair amount of weepage of blood and serous fluid. And so having Mepilex AG, which absorbs fluid, is advantageous. The other thing is that Mepilex AG actually comes off burn wounds or donor sites pretty well. So it's a really good option. So our current option is for donor sites is Mepilex AG. And you asked me another question about donor sites, which I forgot.
I was asking about like, how do you get that the skin that you got from the donor site? How do you get it to stay on the burn wound?
Yeah, so if you just take that skin and you put it on the burn wound, you take that donor skin and put it on the burn wound, the process of healing will just make it stick. In fact, you can see even in the operating room, you put on the skin, and often by the end of the operation, it's not incorporated, but it's sort of like this, just by it sort of slightly drying, it will actually be adherent. So to make sure that but what we don't want to have is this, you put the new skin on the recipient site, you don't want that new skin to shift or move around. And that's where there's several strategies to keep that skin from sliding around. So you can just imagine if you have this brand new thin piece of skin that you put on the cleaned up burn wound, and the kid just rubs it, then you basically have skin over here and the burn wound over here. So different ways we can use to secure it. One is simply just use bandages. So by clever bandage strategies, you can basically fix things down. Another technique is to literally stitch it in place. Using absorbable stitches, put some tiny stitches strategically around the skin graft, and that will keep it from shifting around. Something that I think those who take care of these kids on the floor see us do all the time is to use a vac dressing. And the vac dressing basically uses a suction sponge to basically suck the whole wound and dressings all together into one unit that really doesn't shift around that much. So those are the different methods. Now, one method that that in the past in my training we use, and we really try hard to avoid, is to use staples. You don't want to put staples directly into a skin graft into the patient, because often those staples are very hard to find. And it's not unusual that you bring the kid back to the operating room, you're looking for all your staples that you put in 3 or 4 days before, and you miss one. And then months later, they come and they have some discomfort. So when we use staples, we're always careful to use staples into something that we always can find. So we'll put a dressing on first and then staple the dressing. That way we will never lose a staple. So we do use staples, but never use staples directly to put the skin graft on the kid. And I think those are the main things, Ann, right? Those are the main ways we. Now there's one other technique I should mention, is that you can use. There's some sprays that you can use to help get the skin graft to stick. Right now, those techniques, they're pretty expensive to use. It's hard to cover a large area. It's really not something. I think one day we're going to have some kind of spray type dressing where you put the skin down and you spray something that's like an absorbable matrix, and then you could put some dressing on top. But that's where we're going with this strategy of how to keep skin grafts from sliding around.
Can I ask a question about the donor site? Dr. Bird, how do you decide where to take the skin? Are there some typical donor sites? What's your strategy there?
Yeah, so generally you want to take skin from a donor site that there's a couple of features you look for in the donor site. One is that you don't want to use some cosmetic location. So I'm going to give you some obvious bad choices. You don't want to take a donor site from the face to put on a thigh. I mean, obviously that makes absolutely no sense whatsoever. The second feature is you want to take skin from an area that has not many functional considerations. So you're going to need a dressing. You need a stable dressing on that area. So you don't want to be taking it ideally from a joint, along a joint. So it's harder to put a dressing on. The next consideration is how thick the underlying dermis is in the area. So a great donor site is the back. The back has very, very thick dermis. And because it has very thick dermis, if you shave a little bit off, there's much more for it to grow up from. And then I'm trying to think some other considerations. Yeah, so now sometimes we have a kid who has a very extensive burn injury, and all that stuff falls by the wayside. So we have a patient who has a high percentage burn wound. We have to take donor sites from the best place that we can. And so we may go to our second tier, third tier, fourth tier donor site in order to get stuff healed. I mean, donor site healing can be a problem. And we have a handful of kids that we have in our clinic each year that their donor sites turn out to be more of a problem than their actual burn. They get the burns healed nicely, and their donor sites are incredible headache for the child and the family. And that's why being really careful about how you take the donor site, how you do the donor site dressing, how you take care of the donor site afterwards, it winds up being as critically as important as what you do for the burn injury.
And Liz, what would you say is the number one parent question to you about skin grafts?
Well, I honestly, I'll back up, Cindy. I think it's the number one thing that parents ask at the time of injury. I don't know if Ann and Dr. Bird, you have that experience too, but so often you'll see, a smaller burn, and that's one of the first questions they asked: is this going to need an operation? So I think an important consideration is, we need to see how this evolves over time. Important to keep that in the back of the parent's mind, because we certainly don't want to surprise them, several days post-injury saying, gosh, now it needs an operation. But I think it's it's kind of surprises me how often folks ask that question, from the very beginning.
And so any child that came in through the ER and then they go to the OR for an operation, they're gonna spend the night at the hospital, at least one night. More than likely a few. This is initially, not like outpatient surgery or anything like that. What would you recommend for the bedside nurse to look out for if the patient just had a skin graft? Like what's the main key point that you would want nursing to pay attention to
Yeah,
post skin graft?
yeah. So I think there's, and this is where Ann and Liz can help. I mean, let me talk, since we just talked about donor sites, let's talk about the donor site. So the donor site, first of all, we need to know that there's a donor site. Like, so for example, if we use cadavers, can use allograft, that there may not be a donor site. So having some awareness of what the actual operation was will really help. But if there's a donor site, often these dressings need to be reinforced. Sometimes they even need to be changed early on after surgery. We try to bulk these dressings up so they are absorptive, so that you don't have this problem. But despite our best effort, sometimes the donor site dressing, again, is more of a concern than the recipient site dressing. And then on the recipient site, I think that the strategy is like, what was the original dressings plan, and where do things look now? So, basic things like, is the dressing designed to keep the arm straight? Well, it's good to know that, because if the dressing is failing to keep the kid's arm straight, then that's something that we as a team need to take care of. Is the vac working? And obviously the vac, if the vac's not working, we all know about it because we can't stand the alarm, but is the vac working? And is the child activity restrictions clear? So in general, we have this paradox where we want the kids to be immobilized enough that their skin grafts don't shift, their dressings don't change, the what's underneath the dressings can heal. But we also want the kids to have early rehabilitation, to start using their limbs and to be active and to get back to normal life. So what we don't want to do is have some kid with a 20% burn who's in the hospital for 3 weeks and have that kid just basically sit there stiff. And then 3 weeks later, we're telling that kid that it's time to go home, it's time to go to rehab, and the kid's done nothing. And so having this balance between immobility and rehabilitation, that's where our job as providers, our NP team, and the physicians need to be very clear, so that you as a bedside team member know what we want to do. And if that's not clear, then that's where we need to hear from you.
Yeah, don't hesitate to call our team, especially if there's a concern about a skin graft, and especially if you're concerned about a wound vac, because if a wound vac isn't working and it's over a new piece of skin, we've talked about how that can come from the patient itself, and we certainly don't want to lose a graft because we have mechanical issues. So we're happy to be called and troubleshoot at any point in time. So I think that's a really important message, that we want to be involved and we want to know if there's any sort of problems or concerns. Sometimes it's things that can be troubleshooted at the bedside by nursing or our NPs, and sometimes it's more than that.
I think we need to make sure we're on top of the pain too, because that donor site can be pretty uncomfortable, right?
Yeah, I think the donor site is some of the top issues, right, in terms of drainage and of patient complaints in terms of drainage and pain. Whereas
do they
the skin
itch
graft,
the same way? Do donor sites itch the same way as a regular burn?
Yeah, they do. The way to think about this is that you have some bad burn, and so that burn is painful. If it's deep sometimes it's not painful because you basically kill all the nerve endings, so they have less pain, but most burns are painful. And so a handful of days go by, a day goes by, whatever, and then finally you go to the operating room. And so the pain for the burn injury is ongoing, but it's sort of each day that goes by, it becomes more of a thing that was in the past. The donor site, on the other hand, is perfectly normal skin that has a controlled injury. And so what happens is now the patients will often have significantly more discomfort related to their donor site than they will from their recipient site. And this
Why is that?
well, it's because the burn injury may have, the pain may have be resolving, or the burn injury may have been deep enough that the nerve endings were permanently injured or temporarily injured. And then the donor site is normal skin. And so you're basically cutting into the normal skin in a controlled way. I mean, the way to think about this is, just think about when you're a kid, or maybe not a kid, and you skin your knee. It's a very superficial injury. It heals relatively quickly, but if you recall, when you're a kid, that was a pretty painful injury.
Yeah.
And I think a donor site has many of those same features: perfectly normal skin with a thin injury. And so we've done some specific strategies to deal with donor site pain. One is make sure you have a good dressing, because a stable, solid dressing is more comfortable than a dressing that is moving and flipping around. The second thing that we've done, and this works well for kids who have a well-defined focused skin graft. If you have a very large area, it doesn't quite work. If it's not an extremity, it doesn't work. But if a kid who has a donor site from the thigh, for example, you can do a nerve block in the operating room. And that's been a strategy that we've used that really kind of gets the kids over that early post-operative donor site pain. And it's been a good strategy, but you have to have the right patient. It has to be a relatively small area. It has to be basically a lower extremity donor site, but we do have some options to take care of that donor site pain.
Well, in respect to everyone's time, first I'd like to thank you, Dr. Bird, for coming in and explaining all of this. This has been fantastic, and I think it will be really helpful to our bedside staff whenever they have a patient who went to the operating room for their burn, to really know what's going on in there and what they need to look out for. At the end of all of our BurnCasts, I ask the same question, and I'm going to start with Liz, then I'll go to Anne, and then I'll finally go to you. Of what is your number one take home that you want our listeners and viewers to remember after this talk about surgical interventions for burns?
So I think, as Dr. Bird described, that many things can happen in the operating room, whether it's a dressing change, a skin graft. Maybe you think the child needs a skin graft and things look better, so they just end up with a dressing change, but that there are 4 potential options. And the nurse should feel free to ask questions, but also to really empower himself or herself to know what happened in the OR. To be prepared for either postoperative pain or bleeding or oozing or more dressing changes. So again, that there can be many things that happen in the operating room, and just make sure that you understand exactly which procedure took place.
That's fantastic. And yeah, because it's like, if you know what happened, sometimes with if your kid got a craniotomy versus, there's a lot of reasons why you go to the OR with different people, but for burns, it can be tricky because there's a lot of options.
Many OR trips as opposed
Right.
to maybe just, a fixation of a femur or,
right.
Yeah, or.
So Anne, what do you think?
Well, I love Liz's answer. And also I do have my own answer, but I'm just going to say, when it's a really big burn, the patient goes down with the bandages and comes back with bandages. So you might not know what happened under all of that. So I love that answer.
Yeah.
I think my answer is burns change all the time. So we may say our plan is skin graft, and then we go down to the OR and we come back and we say we didn't have to skin graft, or and that with the fact that burns are changing and healing, and also that our plans are very dynamic. So bear with us if it sounds like we're changing our mind. It really is because of the nature of the injury and how it is a dynamic injury with dynamic plans.
All right. No, that's fantastic. So know what happened. Also know that burns are dynamic. And then lastly, Dr. Bird.
Oh, I think you guys stole my thing. So, I think having, and I mentioned this, having a good understanding of what the child can and can't do. I think that's really sort of useful. And sometimes, we just did a long burn case. We're exhausted. The room's hot, and maybe we didn't put the orders in or weren't terribly clear. It should be clear to everybody taking care of the kid what the kid can and can't do. And when it's not clear, then we haven't really done our job. And that's where we need the other team members to coach us along and say, I can't tell, can this kid stand up? Can this kid bend his elbow that's in this dressing? I mean, all those things, it's our job to make sure that that's really crystal clear, but sometimes we can't think of every possible permutation about that kid's daily care. And that's where we need people at the bedside to help us along to make sure that we do a good job of physical therapy and mobility restrictions or allowances.
So questions aren't just encouraged, they're needed.
Yeah, because it's not unusual that there's some nuance that I just literally never thought of that for a particular kid that comes up that the bedside nurse brings to me.
All right. Well, thank you so much. And we can't wait to see you next time.
All right. Thank you.